third session. This is going to be a panel discussion on the journey to TB elimination. Where do we need more innovation? I'd like to call Dr. Rakesh from the union to moderate this session.
Very good morning. It's my honest privilege to moderate this wonderful panel on where do we need more innovations. This is what we are actually discussing in this panel. Where do we need more innovations in the journey to end tuberculosis? We have seen this entire innovation summit. The entire concept of the innovation summit was like, what are the innovations currently available now to help ending tuberculosis in various pillars of detect, treat, prevent, build. So we have actually seen there are so many innovations now currently coming up. The first two, the lectures have also shown us about the number of innovations that are actually coming up in the detect pillars. We are going to see the other innovations that are going to come. We have seen the priorities also where we need to proceed further. The India is also developing the national strategic plan now. So whatever discussions that are happening here can actually help us there also. Other objective given by ICMR is also to find out where are the innovation gaps. Are there gaps somewhere so that we will be able to fill that gaps properly. So that is basically the objective of this entire panel. We will begin, without wasting much time, I will begin this panel because we have an expert set of people. Welcome Jacob Jones, sir. Sir is also here with us. Maybe I will start with Urvashi, madam, again. Madam is the Deputy Director General of Central TB Division. Madam, the program is currently developing the National Strategic Plan. And what are the three key innovations that we are planning to be scaled up? This is what we are actually looking at. Innovations are available, but we are planning to scale up in India so that we can end tuberculosis. What are the three innovations, ma'am?
Thank you for the wonderful question. And I think we already talked briefly about how we laid down the strategy for the campaign. So let me make the perspective still clearer. I didn't really get the... So what we are trying to do is not only find active TB, not wait for active TB to actually present. That is the classical teaching of 2 weeks cough is, I think, an older concept now. So what we also did was enhance our symptoms to 10S, which is actually now being practiced under the campaign. The ASHA worker is not only looking for the 4S classically defined symptoms, but we're looking for more. So the ASHA workers have been trained and they're looking for these symptoms so that these, the patients who have these 10S can be offered an X-ray. In addition to the vulnerable groups I mentioned earlier, where we are trying to pick subclinical TB or pick TB early, So the idea behind all of it is that we pick all TB. There has been stress on latent TB, but like I said earlier, we've conveniently forgotten the gray zone in between the incipient and the subclinical. And subclinical would inevitably land up into TB, while incipient could actually, become latent and the immune response can actually take care of that. Now, when we're trying to deal with subclinical TB and active TB, the only tools we have is the X-ray, which is, like I said, recommended by WHO. What we did in the campaign was we used screening by X-ray, but confirmation by NAT. I couldn't speak it, couldn't say it earlier. The NAT has been scaled up. We have, again, my team, part of that is here, but then a lot of effort has gone by my predecessors. I saw Dr. Sachdeva was here, and of course the innovators in India, support of ICMR. When I was on the other side in my professor's role at AIIMS, we started the TrueNat study in 2014, concluded in 2018. The program took it up. The TrueNat was scaled up. We have close to 8,540 TrueNat systems in the country, across the country, at the PHC, so which covers patients from all over. We plan to scale up, so you said 3. Let me talk about the screening and the diagnostics first. The screening, I mentioned about close to 400. So the numbers I'm talking is only the numbers with the program. In addition, the partners who are here, who have graced the occasion here, also have facilities with which they are supporting us. ICMR is supporting us. So, like Dr. Gagandeep said, we are going from strength to strength with all partner support. The program has close to 400 mobile X-ray units. And as we talk today, we are freezing a tender that was rolled out for procuring handheld X-rays. This was Global Fund support under the C19 grant, but the domestic support, let me reiterate that. The Global TB report, the WHO report acknowledges that 91% of India TB is taken care of by the domestic support. So I have never faced a no when we go for a requirement for NATs consumables, drugs, quality drugs, X-rays. So we are procuring a good number of more X-rays. And of course, partner support is also coming forward. Another 200, 250 is coming from Clinton Foundation, Gates Foundation support and all. My point being, screening, we're going to be comfortable. We'll have, adequate numbers to cover at least one per district and possibly two per district. We will eventually go to the block level so that screening is put in place properly. NATs, we already have True NATs. PathoDetect has been recommended by ICMR. UVL has been recommended by ICMR. We have to see how we scale it up. We're going to follow the how the program actually adopts a technique. We have feasibility studies first, following the ICMR recommendation. The feasibility studies give us the results. If those are accepted by the technical expert group, we roll it out. So we are in the process, and in fact, we've covered the whole country with the screening and the state-of-art NATs. We only plan to increase our ability further and offer the state-of-art recommended technologies so far as screening and diagnosis goes. I guess you'll give me more time later for treatment and other things. Yeah. Thank you.
Thank you so much, ma'am, for mentioning about that the vision that the program is actually having, and program is actually scaling up. Especially what Madam highlighted is about the subclinical TB effort to find out TB even without symptoms. That's what basically what early diagnosis is going to be the focus. For that, ultra portable handheld X-ray machines are being scaled up, plus the low-cost molecular NATs that are being developed in the country that is being planning to be scaled up, even to the point of, the peripheral health institution level. That's what Madam has been highlighted. Thank you so much, ma'am. May I ask Dr. Suman Rijal, is the Director of the Communicable Diseases of WHO SEARO office. Where do you think, what are the 3 priority areas do you think that we need more innovations to end tuberculosis? Over to you, Dr. Suman.
Thank you very much. And so, as we are all aware that WHO Southeast Asia is having a disproportionately very high burden of TB. In fact, 45% of the global TB burden and more than 50% of the deaths are coming from this region. Now, there has been a high-level political commitments, but that has not really led us to decrease in the decline of the TB incidence. And this is basically due to multiple factors, human factors, health systems, and also resource constraints. I'm talking of the region as a whole. Now, this has been further compounded by, we need to keep in mind, the socio-demographic and the cultural uniqueness in our region in many of these countries. Now, undernutrition and poverty, it's really an important thing to consider. In fact, out of the 5 billion annual cases which are seen in Southeast Asia region, 500 million are attributed to undernutrition. Now, similarly, we need to look at the delay in the access to treatment. We have been hearing about how we can improve diagnosis and point of care tests, but there is a delay in the care to treatment, and that can be due to the stigma associated unawareness or the poor investment in the PHC infrastructure. This also applies for the treatments. Now, many of the countries in the region are also having high co-infections with HIV and other comorbidities, and several countries, private sector, beyond the program also play a role, and many times the data are not being shared with the public health authorities. So we need to have a very concerted and a synergistic approach, and leveraging all the available resources at the national, regional, and in the international sector, as we have been discussing. Similarly, I think research and innovation, especially understanding the gaps, would be critically important. And in fact, this has been one of the pathways which we have highlighted in the regional strategy for Southeast Asia for ending TB 2021 to 2025. Now, before I list you the three areas, I just want to also emphasize that there needs to be a prioritization of the research areas, and this has to be done in each of the countries. And of course, you need to also revise it on a regular basis. At the same time, there should be opportunities for the South-South collaboration and sharing of experiences and innovation and how each country has adopted. And this has been an excellent platform to listen to and also learn of how India has been progressing in that front. Now, my three areas for innovations, I would say, firstly is how can we better use the technology and also have innovative approaches to access care, both diagnostics and treatments. But at the same time, we must remember that we need to continue to innovate and discover new treatments and diagnostics. As we have seen, there are certain gaps that are still required. Secondly, we need to look at it, how can we use the primary healthcare approach as a one-stop shop to address the multiple needs of the patients. For example, the healthcare biological needs for diagnosis, for treatments, at the same time to be able to look at the other comorbidities that may be there and also address undernutrition. We also need to see that how the PHC can engage with the private sector, because they are an important partner there. And lastly, but not least, also the community, because community engagement, both in the planning, implementation, and monitoring of the programs has been prioritized very much these days. Lastly, the third area I would say is we need to accelerate the development of the vaccines. Now, there are 6 TB vaccines in the phase 3, which is very encouraging. But also we need to see, once they are made, once we understand the effectiveness and efficacy, to see how countries can adopt it and use it in the programs. That should also start now itself. So I think these were the 3 priorities, I think broad group of priorities, which I think we need to prioritize. Thank you.
Thank you. Thank you so much, Dr. Suman, Rijal. So you have highlighted 3 key priority areas which you think that we need more innovations on, starting from the strengthening the systems and strengthening the primary healthcare. Second thing you mentioned about partnerships, including private sector and the community to improve the access. And most importantly, the vaccines. That's what you are actually thinking. Let me ask Professor Guy Marks. He's the president of the union. And you know that Professor Guy Marks has been advocating constantly for the population-wide screening for bringing down the burden of tuberculosis in high burden settings. We have even seen the Vietnam study where the entire population they have actually screened, which has resulted in a rapid decline in the burden of tuberculosis there. Professor Marks, what do you think where we need more innovations? Because one of the major things that has been highlighted is about logistically difficult, cost-wise, all these interventions may be difficult. That's what generally the argument is. But where do you think that innovations can help in taking this step forward?
Thank you, Rakesh, and thank you for inviting me to participate in this forum, and to the previous speakers who I think who have made some very important points, and I may reiterate some of those. I think the answer to your question is it depends a little bit. I've been upstairs already and had a quick look around some of the innovations, and they're very exciting. And there is a huge proliferation of innovation in technology here in India that is on display and is rising to the challenge that has been offered. The challenge has been to end TB, and it's clear that there is technological capacity and a willingness to innovate here in India, which is going to solve not only the problem in India, but help to solve it around the rest of the world. But what I think now we need a little pause, not in action, but we need to take a bit of time to think of the context in which these technologies are going to be used. And I've spent my career sort of with one foot in in each of two different camps, one in a public health camp and one in a clinical camp. And I think they're actually the needs and the needs of patients, the needs of people that we see are different in those two different contexts. Much of the discussion that I've been involved in and that many others have been involved in has been the public health focus. And the public health focus is on ending TB. And it does seem clear, because of the very high burden of infectious cases in people who are asymptomatic, that that in high burden settings like India, screening most people in the general population with a test which identifies those of them that actually have infectious pulmonary TB and are capable of transmitting the disease to others is the relevant thing to do, and it is what is going to lead to the end of TB. It's going to lead to TB elimination. The focus of that screening is in fact not for the benefit of the individual who you screen, but for the benefit of the community whom you protect from being infected with TB. And it's very, very important to bear that in mind when we're setting up TB screening programs. It's quite different to screening for cancer or screening for high blood pressure or screening for diabetes, where the only beneficiary is the person that you find. Screening for TB, the person may or may not benefit from treatment, but what will happen is that they will stop transmitting the infection to others, even if they have no symptoms. So we need, for that context, for that public health screening context, we need a tool which is suitable for large-scale implementation. It doesn't necessarily need to be a point-of-care test. It can be a centralised laboratory that does the testing. But we need something which is suitable for mass screening and has to have performance characteristics which are appropriate. That is, that it has a high degree of sensitivity, at least 80%, and which is what we can achieve now with many of the tests, and preferably also a very high specificity, and that's where the nucleic acid amplification tests are in place. At the moment, because of the cost of the nucleic acid amplification tests, we are seeking to mitigate that cost by having a two-stage screening procedure in which we do first-stage screening with radiology, using the handheld radiology and AI reading. And we use that because it is low cost, high sensitivity, but does not have very good specificity. And then we go to the second stage of the nucleic acid amplification tests, only in those who screen positive in radiology. But the only value of radiology in that context is actually just in reducing the cost of the screening procedure. If we had a one-stage nucleic acid amplification test that was cheap enough and scalable enough that we could do it as a one-stage procedure, that would be both simpler, that would be much simpler, and there may not be any need for radiology in that. We're not yet at that point, but I think we are moving towards that point, and that's what we need to look for.
Thank you, Professor Marks, for that. I mean, that wonderful thought. Basically, what we are actually he emphasized the need to do the population-wide screening. We need more simpler tools which we can actually use. That's what basically being looked. It could be a low-cost molecular test. That's what Professor Marks was highlighting. It could be even a centralized test, a cheaper test, that which could be the solution that we can actually look forward to bring in much of these changes, what the innovations that we are actually looking for. We will come back to you, Professor Marks, again. May I go to Dr. Jacob John, who is the former professor from the head of department from the CMC Vellore. Sir has been instrumental in basically in the entire polio eradication programs. Maybe I will ask Professor Jacob John. Sir, what are the three major operational innovations that we need to adopt to the TB program?
Thank you. as a preamble, let me tell you that the point prevalence of microbiologically confirmed pulmonary TB in adults in India per 100,000 people varies very widely from more than 500 in Delhi Union Territory to less than 200 in the Kerala state. So with such wide geographic variations, TB control and elimination must be designed, applied, and evaluated district by district. Now for the three innovation points. First, we need to design a method of objectively monitoring the incidence and its decline trajectory over time. Deja vu. Remember my original design of sentinel surveillance for HIV? So if you think it's possible. Second innovation, we need preferably legally mandated annual health checks for all employed adults, captive audience. Keeping in mind both NCDs, non-communicable diseases, which is the major problem in the country, and TB, which mimics non-communicable diseases. Then expand to all unionized employees or organized sector, then move on to self-employed people. So it's possible to do this and be very, very productive in controlling both TB and NCDs. Third point, having heard the unknowns of the natural history of TB, we who understand it ought to educate all doctors from primary health level to super specialty level to think of suspect, test, diagnose, and treat both pulmonary TB and extrapulmonary TB, and link this seamlessly with NTEP so that a stigma-free environment can be created for diagnosis and treatment. Thank you.
Thank you so much, sir, for that suggestions. You mentioned 3 points. Objectively monitoring incidents is something which we actually need, and we need more innovations in that. The annual health checkup, which you are mentioning about, basically screening everybody in the employment sector, is something which you are actually looking for an operational pathway. Third is training of the providers and integrating well with the program. So these are the lessons that you have actually, these are the 3 areas that you have actually suggested. Thank you so much, sir. Maybe I will ask Chapal Mehra. So he is an independent writer and a public health specialist sitting with us. Maybe I will ask from the community perspective, I will ask the same question. What do you think are the 3 key innovations that we need?
Thanks, Rakesh. It's interesting because when you work with communities, you realize a few things, that their priorities are actually not the same as the priorities of doctors or of the health system very often. And they converge to the point of cure because all patients want to be cured, all affected individuals want to be disease-free. But just a point about innovation, I think innovation is how you define it. When doctors and scientists define innovation, it has always to do with medicine and with science. When communities define innovation, it has to be with daily issues of struggling with a disease which affects sometimes not one individual, but the entire family. And I've worked with so many TB-affected families. It doesn't even happen in one go. It happens over years. First, one parent gets it, then another parent gets it, then the children get it, and it's an endless cycle for them. So when you look at priorities from the point of view of communities, their priorities are actually quite different. For instance, when you talk to them, some of them ask the most basic questions about the disease. In India, TB is stigmatized, but actually communities know very little about TB. And this is very, very confusing for them. How did I get this? How will my family react? How will the issues of managing life on a daily basis? Because most people here talk about TB without putting the face of the individual, because most often that individual man, woman is a breadwinner. So for them, the biggest issue is not that they've got TB, but the biggest issue is that the innovation that they need is a support system. So if I were to look at 3 areas, I would look at how do you provide a diagnosis and treatment that works for the community, the poorest person in the crowd, because all of us are in that way to a large extent entitled. So we can take the economic hit, we can take the social hit, but we do not know and do not understand the realities of people living in an informal settlement in Mumbai, encountering MDR-TB, nor do we understand that they will be kicked out of their housing if they are ever discovered to having TB. So those are the things those are their priorities. Their priorities are not, how short my treatment became all the time. Short treatment is, of course, an important issue. The right diagnosis is an important issue, but there are overwhelming economic, social, and cultural issue. Very rightly, somebody mentioned stigma. It is an overwhelming issue for communities. They will resist getting the test. They will resist treatment. They will interrupt treatment. Not because they want to, but because, those are issues for them. So for me, the top 3 areas, because I know we have limited time, is how do you provide care which works with communities at the level that they need it? Number 2, how do you provide them the economic, social, gender-based support that they need? And the third thing, which is very overwhelming, is how do you assure them that their side effects can be managed? Because this health system has no management for side effects, for mental health, and for post-cure recurrence of TB. This is the biggest question every TB-affected individual asks. Can I get this again? And the answer, sadly, is yes, you can, but we don't really have any innovation that targets any of these 3 areas. So I'll just stop there.
Thank you so much, Chapal, for highlighting those 3 key issues. All these are very relevant key issues that you highlighted. Working with the community, looking at the community, and see how the care could be appropriate for the community, how best can we provide, along with the addressing the side effects and also economic, social support, what best we can do for the community. These are the 3 areas that you think very important, very relevant. I will ask Dr. Madhukar Pai. He's the professor and chair at the McGill University. We have seen there are lots of innovations now available with us now, but access to the innovations is something which we need to really think about. How could we improve the access to the innovation? What is your thoughts on that?
Thank you, Rakesh, and thank you for also asking me to speak about this at 2:30. So if any of you are interested, please come for the lecture. I would like for us to really start challenging what an innovation really means. I think Chapal did that already from a community perspective, which I greatly appreciate. Now, let's take 2 contrasting examples. The mRNA vaccine technology won the Nobel Prize. Truly a breakthrough in science, genuinely worthy of a Nobel Prize. And not only was it helpful for COVID, it's now being repurposed for a whole bunch of things, including targeting cancer. Spectacular innovation. But billions of people on planet Earth never ever saw an mRNA COVID vaccine. How many people in this room have received an mRNA vaccine for COVID? I have, because I was lucky enough to be in the global north, but most people in this room have never seen one, let alone boosters that are updated by every COVID variant that's coming along. We got annual boosters that were titrated to the most dominant variant at the time. So here is a Nobel Prize winning innovation that virtually never reached the global south, and even today, this entire mRNA platform is a monopoly of 2 companies, Pfizer and Moderna, and is a monopoly of global north countries. The whole of Global South has been locked out of a Nobel Prize winning platform. Is that an innovation? I'm not sure about that, right? Now let's flip to another example. Giving food to someone with TB, whether it's a basket of food or whether it's a cash transfer or a DBT, none of us would see giving food as an innovation. And yet, it has a miraculous impact on people living with TB and their families. Truly, there is not a single study that has shown that social protection for TB does not work. It works. It's as simple as supporting someone with the social benefit, and it has a miraculous impact on tuberculosis and families. So to me, innovation without access is what Paul Farmer called excellence without equity. Excellence without equity can only go so far. And we've got to resist this thinking that getting a great gizmo or an innovation that only reaches the elite privileged few in the world is not really an innovation. I think real innovation comes from making it accessible to people. And this goes back, and that's my last point, that there are two fundamental human rights that I think we all care about, right? One is very clear, that health is a basic human right. Everybody in this earth deserves access to health and healthcare. But there is also a second human right enshrined in the same UN Declaration for Human Rights, and that is a right to the benefits of science. The best science, when it produces something truly beneficial for humankind, if that is not accessible, then it's a violation of human right. We rarely talk about this human right, but it is there. Access to the best that science produces is also a basic human right, and we have to fight for it. So terrific innovation that doesn't reach people, to me, is really not an innovation. Thank you.
Thank you. Thank you so much, Dr. Pai, for highlighting that point. Yes, it's a right. We have so much innovations now, and making it accessible to the people is something which we really need to work on. That's what being emerging from this panel generally. I just want to ask, I'm saying we all agree to that point. We just need to improve the access to the innovations to that point. But I have been specifically asked to find out if we really want to have one more innovations to ending TB. If we really want to have one more innovation in ending TB, what could that be? This is something which I am just specifically asking. We want to have one more innovations in ending TB. What could that be, right? Maybe, ma'am, if you want to have one more innovations in TB.
So, no, Gagandeep also raised that we are happy to enhance our NAT, but we are dependent on sputum production. So this is one issue we faced during the screening of asymptomatic individuals, where the vulnerables we wanted to diagnose after their X-ray picked them as abnormal. Sputum production was a catch. Now, what I'm actually trying to arrive at is the ideal most test would be a non-invasively collected sample, a swab, or I would say, why not some other non-invasively collected, it could be urine. So we've had the LAM test, but that doesn't really match up the sensitivity for screening. Specificity is high, but we'll miss out some cases. So there is that window for all the researchers so in the times of transcriptomics, proteomics, all kinds of omics technology, we're still looking for that test which will diagnose with high sensitivity, high specificity in a non-invasively collected sample, which we could offer to all vulnerable groups, possibly going on the Japan model, screen mass population, where, if you ask me, we would like to go. But then, there are several naysayers who believe there are people who would even object to getting an X-ray. Oh, I'm healthy. Why should I get an X-ray? So this is where I echo the statements made earlier. Stigma is an issue. Awareness, we have worked so hard, ICs, etc., being displayed all over. But again, we possibly should reach each and every individual to make them aware. Dr. Soumya showed some pictures of a tribal village where the program is trying to reach, making great strides. But yes, we have to reach every individual. One, to increase awareness, to tell them the symptoms, to be able to screen them using a non-invasively, possibly just a dipstick test, which is, good sensitivity, good specificity.
Great, ma'am. And that's something which is really what is being a non-invasive test where we can use simply is what the wish list of madam is. Maybe I will ask Dr. Suman Rijal, what is that one innovation if you really want new innovations? What could that be?
I somehow would like to re-emphasize that what Madhu said is we need to make access, of the current innovations. This is I think we need to have innovative ways to make this available, accessible. And I think that's something which somehow we ignore. And I have seen this not necessarily only tuberculosis, but every diseases which we are seeing. Look at neglected tropical diseases. I mean, even if you have a innovation there, the access becomes such a challenge because either they don't get registered or there is no manufacturer who wants to manufacture in a large scale, or there is no distributor for that. So I think we need to also look at innovative ways to make it available. And here, I think we need to look at what are the resources we have. And one of the resources which I would like to allude to is using the community. This is where I think communities can play a great role to bridge the gap from getting the access being made available.
Great point. Maybe I will ask Chapal, what is the one thing which you...
I love the term using communities because everybody wants to use communities, nobody wants to listen to them. And this is wonderful. Everybody's got an idea about how to use communities, but the health system can't be fixed. The communities will come and fix the health system also now. Interesting point, but I will say that my number one priority would be family and patient support, which is comprehensive, includes, I think the program is also already doing food support, but I would look at comprehensive support, side effect management, mental health, and also looking at familial support, because we don't realize most of India lives in a room. We don't have 2 rooms, 3 rooms, people who get affected by TB. There is no such thing as isolation. You really need to find a way to manage it within families, to take care of caregivers also, because TB is a long battle. So that's the thing. Yeah.
Thank you so much. Professor Marks, what is that one thing you need?
Look, I'm not sure that I can answer that, to be honest, Rakesh. I don't think there is one solution. I think we have a lot of technology, and as I was implying before, we need to use it better. I just want to take my 1 minute, though, to make a comment to Chapal about about communities. In countries where TB is uncommon, like the country which I come from, if there is a person who has TB in the community, then there is usually outrage, and people are trying to find who to blame for the fact that they were allowed to catch TB. I would like that to happen here in India. I would like I would like people to be outraged that they were allowed to be infected with tuberculosis. And I want to know how you achieve that in countries where there needs to be a bit more outrage about the fact that TB is still allowed to spread and it's not being, people are allowed to be exposed to others in the community with tuberculosis. I want to see how we can achieve that.
Thank you, Professor Guy Marks. Jacob Jones, sir.
I would shift gears and suggest or recommend a process that takes on from here and continues regularly to look at TB. And the animal is called India Expert Advisory Group on TB Elimination, with an independent chairperson with secretariat at the division, Central TB Division, with ICMR experts on tuberculosis, infectious diseases, epidemiology, and representatives from all states in India and union territories and international partner agencies, national and international partner agencies. India Expert Advisory Group on TB Control and Elimination, meeting twice a year. Thank you.
Great thoughts, sir. Dr. Pai, what is that one thing?
I think I would genuinely love to see a really much more efficacious TB vaccine. And the fact that in 2025, we are still using BCG that was trialed in 1921, I think is a spectacular shame on all of us as a community that we have not aggressively pushed for a better tool. And the amount of investments that went into COVID vaccines, which is in the order of billions of dollars, because rich and privileged people got infected with COVID, while TB primarily affects Black, brown, and indigenous people. We are hardly investing in TB vaccine. And this is genuinely a shame, and we've got to fix this. Thank you.
Agreed, Madhukar. I think it was very interesting panel with lots of discussions coming up, saying, generally, before I summarize, may I request Urvashi madam, after hearing all these things, ma'am, what is that we need for India now? Like, one, we heard about new innovations that we may need. There are some wish lists, but at the same time, we may need to enhance the access to some of the innovations that we already have. For the upcoming new national strategic plan, what is that you want to conclude from this entire session in a minute?
Yeah, so you've limited my time. Thank you. So let me acknowledge what Dr. Suman said, that we need to improve access. So what I want to acknowledge is, probably this is the golden era for the Global South. We have been able to improve access to, like I said, door-to-door handheld X-rays, NATs. We talked about the numbers we are reaching. So far, with the available recommended diagnostics, what I also acknowledge is we do not have the best possible diagnostic. If we, people give us examples, follow the Japan way, follow the Vietnam way, we would. So I also acknowledge what was raised by Mr. Chapal, that the community has to be part of our efforts. So at our end, I can see all the faces here are all champions who've spent their, major part of their lives trying to enhance TB care, the experts present here. So the effort from the side of the experts has been immense. The community has to be on board, has to share the issues they face, so we are able to address those. The gaps I see are only two. One, diagnosing all those who may be actually disseminating TB in the community. So here I acknowledge what Dr. Guy Mark said, but that's a very revolutionary statement. That so of course the fact that undernourishment and TB have a synergistic or a two-way role, one enhancing the other. So which we have taken care for the TB patients. We are trying to enhance not only the patients, the low BMI patients, and also we've expanded to the families, as was found in the ration study again, ICMR supported. What will be the final solution for us? Well, the final solution could be population level nutrition intervention, which again is a far-reaching dream. And what Dr. Madhu said, the vaccine. Till such time we have these two main interventions, we are, constrained to actually, so much effort is going into finding cases, so basically closing the tap. What we need to ensure is ensuring immunity so that the infection doesn't transmit or doesn't find a new patient. Where only till such time we have the vaccine, nutrition is the vaccine we have. So with these words, I think I can conclude. Thank you.
Thank you so much, ma'am, for concluding. So I have, I'm not taking much time to conclude, but I really enjoyed this panel. There are so many thoughts that has actually came in. There are some needs for new innovations, but at the same time, the panel also emphasized about the focus, where the focus needs to be, and how to utilize the available innovations, how to take it up, make it more culturally appropriate, community appropriate, and how to take it up to the scale and how to improve the access to the innovations. That's what I'll stop this panel here. Maybe we'll discuss in detail more and more about this while we are here for the next 2 days. I am stopping this panel here. Thank you so much for all the contributions, and it was such a wonderful panel. Thank you so much.